Okay. I think we should start. Good morning, everybody. It's a pleasure to be the host for this webinar today, August 16, 2020. This is the second webinar in our series. It has been a great success so far, so please keep us, give us feedbacks and then stay tuned for the future webinars. Today we have two outstanding speakers that will talk about methods for, or technical methods to minimize brain dysfunction from mesial temporal lobe epilepsy surgery. And I would like to introduce our speakers. We have Dr. Chris Smith. He is a professor of neurosurgery at Barrow Neurological Institute and director of the Functional and Epilepsy Surgery Service at Barrow. Dr. Smith is a well-known, respectful, outstanding surgeon. He's going to talk about his methods of approaching the temporal lobe pathology through a subtemporal approach. Following Dr. Smith, we're having Dr. Alexander Weil. He's a professor of neurosurgery at University of Montreal in Canada, and he will talk about the posterior fossa approaches, and more precisely the supracerebellar transtentorial approach for mesial temporal lobe pathology. So without any more delays, I'd like to have Dr. Chris Smith to start, and I'd like the attendees to please, the order here is going to be the two talks will happen subsequently, and then after we open the discussion. So please send us messages with your questions, and your questions will be answered at the end of the webinar. So Chris, Dr. Smith, welcome.
Yes, thank you. I'll share my screen. Should be out.
Jorge would have to unshare first, otherwise.
Jorge, you have to unshare your screen. There we go.
Okay, well, it's my pleasure to be on this wonderful seminar. We're going to talk about this subtemporal amygdala hippocampectomy, and something I've been doing and gradually over the past really 25 years. So it's something that we feel strongly about here at Barrow. Let's see if I can make the slide. So I don't have any relevant disclosures. So I'd like to describe the operative nuances which allow for this procedure to be successful. I will state that my passion for the minimal access surgical philosophy to preserve neurocognitive function and to help decrease morbidity without compromising on long-term seizure-free outcomes. And so this is just a reference. I think this is something of the past, and I use this as in kind of tongue-in-cheek, but I know there are still a few places that kind of approach epilepsy surgery this way, and I think that's something that we don't have to do anymore. And this is really the incision that is done by my modern technique of doing the subtemporal approach. It's really a very small procedure, and it's attractive to the neurologists to refer patients, which is a big hurdle to overcome. That when they refer patients to me, it's not about a big morbid procedure, but a small incision, and the patients are much less frightened by that and more willing to undergo a surgical procedure when we talk about it. And this is just, obviously we have newer things. It's an MEG and our new SEEG electrodes, my philosophy of just placing things without shaving people's heads and making it less of an experience for patients that's frightening. But the goal is not to make it small, but it's really to free people of disabling seizures. To maintain their function as much as possible. They're really more interested about driving and independence. And so again, I'm probably preaching to the choir out there, but just really thought it was necessary to see where we've come. We went from the bigger temporal lobectomy, which is still done, many places, in fact, probably most places. Then there's the Spencer modification there in the orange line. And then there's even all the way down to laser ablation. So this is just a single stitch operation. And so for us to pick out which one is best is an interesting challenge, and now even NeuroPace and device. So just like to show, this is a post-op image of a laser ablation case I did, which does show the line of ablation, but you have less control with that as far as the heat spread out. Especially, I'm interested in preserving the lateral temporal margin where the optic radiations are. So back in 2009, we published our first, version of this, and have made a few modifications since. And just a couple months ago, the larger outcomes were published. So this is available to look at the data. And it's really about, doing this through a keyhole approach, which is something that, in the past when I was in training, it was all exposure, exposure, exposure. We want to get everything visualized, but I believe this keyhole approach is very doable, and you rotate the patient through a small window to open and do things. So there are many approaches for amygdala hippocampectomy, and transsylvian, transsulcal, they go through the lateral temporal lobe and then the subtemporal one. And on this diagram, the supercerebellar infant tentorial approach is not shown, and that's what Dr. Weil is going to talk about, which I think is also quite interesting. So again, typical patient with a mesial temporal lobe that is sclerotic and really quite different than the other side. And you ought to have, obviously, the workup to make sure that they don't have bilateral seizures and all of that. It's really important. And then if you have a PET scan that shows that as well, we love that. And then this is showing depth electrodes for patients, showing that the mesial onset seizure is really what's happening. And if that's done repeatedly, then the patient's a good candidate. And this is just showing a post-operative MRI, again, showing what we wanted to show, that there's really the entire hippocampus mesial structures are out. It goes all the way back to the level of the collicular plate. This is a higher cut, but there's no injury or trauma to the lateral temporal lobe. And that's the goal. Again, the understanding of the hippocampal anatomy is incredibly important. A slide that shows this is really the access point that you need to be aware of, where the blood vessels come in. And this later will be seen as something that has to be visualized correctly in surgery. It's called a hippocampal fissure. But again, going back to the anatomy that's relevant, from
Chris, I think we lost
the
your
optic tract. Let's see. Sorry about that.
No, you're fine now. Can
Back. Okay.
Yeah, go back and restart on that last slide, whatever the
Okay.
was, because we lost that audio.
Okay, this one?
This one, yeah.
So, yeah, okay. So it's important to see the relationship, the lateral Meyer's loop from the lateral geniculate coming out and going around the outside over the top of the temporal horn. So if you come in underneath in the inferior aspect of the temporal horn, you don't violate those structures. So again, this anatomy from the surgical standpoint is very important. It's obviously a cadaver specimen, kind of blown up and separated, but it does show the posterior cerebral artery medially. Now the hippocampal arcade are vessels that come off of the PCA. It says in some textbooks anyway, that the anterior choroidal supplies the hippocampus, and I really find that to not be true. It's the PCA goes directly into the hippocampal fissure and feeds the hippocampus directly. And there's usually a main hippocampal artery that's right at where the apex to the peduncle is here, right in the mid, where the body and the tail, or the head and the body of the hippocampus are divided. And that's a real important key to doing this. And you never want to see this. Actually, you'll see in the videos that I show, you do see the optic tract above you through the pia. You don't want to see it you don't want to see it exposed without the pia there to protect it, and that's one of the main goals of surgery. But the amygdala will come out first and expose the hippocampal head. The choroid plexus is right here. What I'll show is our friend to really guide us through the anatomy of the temporal lobe. And again, this approach here comes in from below, and the optic radiations are above. So To come in anywhere through here, you're risking at least an upper outer quadrant defect, if not more. But coming in from below through the collateral sulcus and up spares all of that, and most importantly, spares these connections to the temporal stem that would be violated if you come through a transsylvian approach. And again, coming in from below, where the optic radiations are above you. This is some anatomy from our first publication, kind of looking up, and you see through the PL membrane, you can see optic tract. This is the third nerve through it, and this picture, where we see the hippocampal fissure with the vessels going into the hippocampus, that becomes very important to look at that, identify it directly, so you avoid a stroke by taking only the hippocampal vessels, nothing within the fissure. So this video is an old one. I purposely picked an old one because I did it through a, whoops, go back. Should play, thank you. It's not the slickest video, shows some blood there. We've gotten better at editing videos lately, but this one, it shows us the small little telfa that's placed underneath, and it's really important at the beginning to have the patient in reverse Trendelenburg position, so the head is up. And the anesthesiologist obviously uses mannitol, and we use dexamethasone, everything. And this is even when I didn't have minimally invasive bipolars with a lower profile. And but it's important to just let the CSF drain out. And in this one, there'll be I had a little Greenberg retractor at first, and I got away from that. So through this field here, you can see there's a little tiny venous bleeding as you're taking the tissue off of the peel surface. I don't worry about that. I don't use the bipolar cautery hardly at all, and it just kind of stops as long as you stay in that subpeel plane. And in the center there, you'll see there's a third nerve. Now this is really important. You're in the temporal horn of the ventricle, and that's what gives you the anatomy. You really follow the choroid plexus and always stay below it. This is showing opening up underneath. This is the posterior choroidal collateral sulcus, and I'm going around that larger vessel there. I don't take any major vessels on the floor. I simply spare them. If you take a lateral vessel and or an inferior artery, you're going to cause an occipital infarction because the vessels go from front to back. This is showing freeing up the head of the hippocampus right at this point where the main feeder, the main hippocampal artery, is coming through the hippocampal fissure, and you want to take that out as distally as possible into the substance of the hippocampus. You don't take it right at the choroidal fissure in the subarachnoid space. You take it out in the distal hippocampus, freeing it all up, and then cut it. And that's usually the last step of the main block. This is just separating it off the back with a ultrasonic aspirator device, or many different brands. They're all fine. I like the finest tip possible if I can. And then as you free it up in the subpeel plane, you're able to then disconnect the body from the tail, and then it comes out as a end block resection. And we've used those for slice recordings for the researchers. So that was an older one. It's really the same. I think going through it a couple times helps. This is actually a published video that's on the JNS website. And I'll just kind of skip through some of the beginning of it here. And again, showing this one's very sclerotic, patient with atrophy. And there's really questions sometimes of why you would have a video. The audio for me is too loud. Sorry about that. So the reason to use this, even on the right side, has been questioned about by preserving function, but even the right temporal lobe. We've developed our neocortex for a reason, for social integration, for all kinds of things. I think either side is necessary. This is important, the video showing the positioning of the patient. So we have a bump under the shoulder, leaning up, the head is nearly flat, but is angled down somewhat the vertex because you have to come from inferior to superior underneath. I've converted to a curved incision over the ear like this, and it turns out I used to do it through a straight incision like this, but I was fighting some of the muscle. I found that going over the ear is very, very helpful because the thickness of the temporal lobe, right, the temporal bone, closest to the body of the amygdala as you go back a little bit, and through this keyhole window, you can go both anterior and posterior from that middle approach. There's very little section. Again, I show this keyhole idea of starting. I always start in the front, and I'll go through that a little bit. That's because beginning, you want to go, you're not as relaxed as much until the temporal horn is open and that interventricular CSF gets drained. So by going underneath anteriorly, at first it's a little bit tight, but with the right positioning and everything, just gradually you're patient, let CSF come out. I'm looking very inferiorly, just at the dura on the top of the petrous bone, top of the bone, and we're coming in again underneath patiently. These are actually striker, what I call my minimally invasive bipolar set. That's a narrower set that allows me to see through the opening without the body of the hippocampus, body of the bipolar is blocking my view. And again, this is a right side, so we are doing the amygdala first, and I have image guidance over here showing where I enter, which is right below the tip of the temporal horn. And one thing that's really important, I'll show this at the end, the image guidance system, because we're retracting and brain is relaxed, it'll show you that you're higher than you are, deeper than you are, which can be scary if you're used to really using the image guidance system. And let's see, get that going. But it really helps you to know where you are on an anterior and posterior plane, but don't worry about the depth. This is really important because it shows the collateral sulcus. So I open the pia just past it and then come back up and under. This is connecting the original resection of the amygdala and then going back along the perihippocampal gyrus floor from front to back. And then you cauterize the pea a little bit, but then you stay subpeel while you dissect out and remove the perihippocampal gyrus from below. This is doing that. This creates space. It creates space so that when you push the hippocampus down, so this is entered into the temporal horn, you see that head of the hippocampus. You now have space to push that down into. And you have a cotinoid protecting the choroid plexus. That's very important. And then you see the choroidal fissure, and then that is the hippocampal fissure that is separating and is where the feeding vessels go into the body of the hippocampus. Again, this is pretty consistent anatomy, although obviously there are differences from person to person. And some people have, 1, 2, or 3 pretty significant hippocampal arteries. Most people have a pretty major one right at the apex of the peduncle. Again, if you see where this is, it shows I'm too deep. That could scare you. You're in the brainstem. You're not, because this patient had a lot of atrophy and was falling away. And then you see that hippocampus coming out. And after the back has been removed, I chase the tail. I say that tongue in cheek, going back into the tail of the hippocampus. And then at the end, I use avatine to place within the bed along the field surface that's been preserved and along the floor. I let that sit, then I irrigate it out. And that's been a very successful thing, to really not use the bipolar down deep very much. This again shows that we're in the front initially. The temporal horn, the amygdala at first. If I remove the amygdala first, I open the tip of the temporal horn and lets the spinal fluid come out and helps everything relax, and it's the safest place to enter. Again, this would be frightening if you weren't really aware of your anatomy from the inside. Knowing that the patient's atrophy was falling deep and superior lets you have to be dependent on your own internal view of the anatomy to really make this a safe operation. We'll go to the, and then this is again the post-op result. Hippocampus removed, and again, because the atrophy of this patient, There can be a little subdural fluid that's just water. Don't worry about that. That resolves and goes away. So I thought that would be an interesting one to show some of the potential concerns that people might have during the surgery. So we'll go to the next slide. So as our seizure outcomes go, we looked about 10 years data and angle. If you had MTS, if you had obvious sclerosis on the MRI scan, our success rate is incredibly high, with almost 90% people being angle 1 and 2 outcomes. But I don't really recommend this anymore for patients who have a normal looking hippocampus on MRI, because the cognitive outcomes are definitely worse if you're still using that for functionality. So things like neuropace and all of that are really interesting. So they really did very well from a neurocognitive outcomes with almost no difference in any claim in any domain of neuropsych function. However, there is a word retrieval issue regardless of right or left side, but our complication rates were very low, 0% mortality, and only 1.3% rates of any. There was only one patient with any visual problem, and that was due to a deep occipital infarction. So I think that's pretty good. So I think it's favorable for sparing temporal cortex and connection pathways to the frontal lobes. It helps us with our neocortex and maintaining all of our higher human abilities. The operative technique does require comfort with the complex temporal lobe anatomy, access through a small corridor. It's a challenge for our residents to learn this. They really look forward to doing these with me, but they do claim that's one of the hardest things they learn. And I don't mean it to be difficult, but you just need to be comfortable in small spaces, and that does take some experience for sure. But I think the neurologists really like this because it's less morbid. It's for the patient, they recover quickly with a very small incision. So the pearls, again, we went through these. The reverse Trendelenburg at first, you have the head up, you have everything relaxed. You take patience to get CSF out at first. Again, I start under the amygdala, resect until the temporal horn is opened. The view of the choroid plexus and fissure have to be very clear, and everything should be done with this subpial dissection technique and pulling that hippocampus down into the created space. Makes it work. You have to bipolar and cut the hippocampal arteries only after you're absolutely certain it's not a choroidal vessel. That could be a disastrous stroke complication. So you have to be very clear about that. I think it's better to enter, if you have a temporal vein that's on the floor, everyone worried about the subtemporal approach. Dr. Spessler was frightened to death. I'm causing vein of lobe avulsions and things like that. I haven't had a single one. But every once in a while, if you pull up on the temporal lobe, you see some venous bleeding, just throw some surgifoam down there, relax, and don't pull up on any of the temporal vessels. Let them stay on the floor and enter the inferior temporal surface at a more lateral place rather than risking the venous avulsion. And I never, ever place a retractor anymore or lose position above the choroid plexus. If you're doing that, you're retracting on the descending fibers, and you're in the thalamus, you're in the basal ganglia, and the choroid plexus is your friend. That really is what guides you. If you're below that and have a visualization of it the whole time and stay below it, you shouldn't hurt anybody. So thank you very much. Hopefully that was useful.
Thank you, Chris. This was a wonderful and very didactic presentation. I really enjoyed it. I have a couple questions. I'm sure the attendees and the panelists will also have questions. So I will ask the whole group to hold the questions for the final. And for sure, this was we're gonna create a lot of discussions here. Thank you so much, Chris. Appreciate it.
You're welcome. Thank you.
Welcome. So without any delays, I'd like to call for Dr. Alexander Weil from University of Montreal. He is going to talk about the supercerebellar transtentorial approach for mesial temporal pathology. Alex, go ahead.
Thank you, Dr. Gonzalez-Martinez. Well, I'm honored and very privileged to be here amongst this esteemed group of colleagues, all of whom I look up to. I'll be speaking about the paramedian supercerebellar transtentorial approach. And I can't talk about this approach without talking about my mentors, with whom I trained and who taught me this approach. And I was very fortunate in my training to train with Dr. Bojanowski during my residency and Dr. Bhatia during my fellowship, both of whom were stellar mentors who had extensive experience in the SCTT approach for epilepsy and other pathologies of the medial basal temporal lobe. And I'm grateful and indebted to both of these mentors for having learned it. So the paramedian SCT approach, Professor Yazego developed it and reported in the 1970s, initially to treat cavernomas of the posterior hippocampus. And his rationale was to remove the cavernomatomus pathology and preserve visual pathways. And that really is the cornerstone and the rationale to this approach, whose objective is to resect pathology of the medial basal temporal lobe from an inferior approach through a suboccipital craniotomy, passing above the cerebellum and through the tentorium in order to reach and remove pathology of the medial temporal lobe while preserving both visual pathways and the eloquent white matter and cortical structures that are at risk with other approaches lateral to the medial structures. And I won't go through the details of it, but essentially we're all familiar with the various approaches to the medial basal temporal region, whether it be hippocampal sclerosis or another lesional pathology. Most standard approaches are associated with either a variable rate of visual field dysfunction or risk of neurocognitive impairment, either from retraction or transgression of various structures. Without going into too much detail, the SCTT approach, although initially developed in the 70s, has been used more and more over the last 5 to 10 years, and overall the rate of visual field dysfunction is quite low. Most reports, most centers are a 0% rate, up to 9%, in addition to reducing the risk of associated with retraction or transgression of other cortical structures. So the rationale that Yazego developed holds true today. In order to discuss this approach and perform it, of course, you have to have an excellent working knowledge of the temporal lobe, as everyone in this webinar has. But it's worth briefly reviewing the classification of the medial basal temporal lobe. And essentially, you can divide the medial basal temporal lobe into 3 thirds, an anterior, middle, and posterior third, limited laterally by the rhino and collateral sulcus, medially essentially by the ambient and crural cisterns. And without getting into too much detail, we can see that essentially a selective amygdala hippocampeectomy is a resection of the anterior and middle portion of the medial basal temporal lobe. And the SCTT approach is an excellent approach to reach these structures for patients with hippocampal sclerosis. Of course, many centers have MR-guided laser ablation, as does our institution. And so in patients with MTLE, with clearly shown hippocampal sclerosis, this will be our first line of treatment. And multiple reports have shown a very low rate of visual field deficits and, of course, neurocognitive benefits. As Dr. Smith pointed out, this does potentially come at the risk of incomplete ablation of the mesial structures. In my practice over the last 5 years, I've been essentially using the SCTT approach for for lesional non-hippocampal sclerosis of the medial basal temporal lobe. The majority of cases being neoplasms, although many others have treated AVMs, cavernomas, and other types of tumors. And while it can be used to reach the anterior middle portions of the medial basal temporal lobe for hippocampal sclerosis, the ideal lesion that can be reached by the SCT approach are more posterior located in the middle and posterior medial basal temporal lobe. And although it's an excellent approach which can provide good exposure to the entire length of the medial basal temporal lobe, the more anterior portion can be challenging. Why? Because the petrous ridge laterally and the midbrain medially can obscure the view of the structures. And so for anyone embarking on their first cases of in which they'll be utilizing the SCT approach, I would certainly recommend starting with a more posteriorly located lesion. Of course, there are other limitations. Posterior lesions that are more towards the occipital lobe or higher lesions will be difficult to resect through this approach due to the blind spot caused by the transverse sinus. And also a more superior lesion, you're gonna have to potentially traverse a significant amount of cortex, and that would not be desired. So in addition to lesional sort of restrictions, there's some certain aspects that are important to assess for each patient, even if they do have a lesion that's amenable to the SCT approach. Important to look on the MRI, the tentorial angle. Patients with a more brachycephalic head shape and often have a higher or steeper tentorial angle, as you see in this image. And that can render the approach much more challenging, particularly to the more anterior part of the medial basal temporal structures. Another very important thing to look at on preoperative imaging, whether it be MRV or CT venogram, is the venous anatomy of the patient. It's not always clear or evident how the veins are or which veins are going to be the most pertinent, but certainly you would want to try and see if the patient has a venous anomaly or a venous variant whereby the venous drainage of the inferolateral temporal occipital cortex passes through the tentorial sinus, which is present in about 10 or 15% of patients. In an approach that traverses the transverse, the tentorium, and potentially sacrifices these tentorial sinuses, this could lead to a very significant complication of venous infarction of the medial basal temporal lobe. So certainly something to look out for. In addition to other venous anomalies like abnormalities of the basal vein of Rosenthal or superior petrosal vein, if their drainage is aberrant towards the tentorium or tentorial sinus, these would be things to look out for and would potentially be contraindications to the approach. Now, how does one safely resect the medial basal temporal lobe, particularly the posterior portion of it, through the SCT approach? There's really 4 steps to follow. It's performed through a suboccipital craniotomy, initially a supercerebellar approach, exposure of the perimesencephalic cisterns, opening of the tentorium to reach the supratentorial space, and resection of these mesial temporal structures. Now, most centers and most surgeons actually perform SCTT approach through a sitting or semi-sitting position. I learned it on a park bench. This is what I'm familiar with, and this is how I've been carrying out this procedure. There are certain advantages to the park bench, of course. In addition to familiarity, there's a reduced risk of air embolism compared to a semi-sitting approach. Ergonomically, you can sit, positioning of the arm can be rested on the myostand or on the shoulder gently. The disadvantage being you can't benefit from the gravity-dependent retraction of the cerebellum. So if you're going to carry out this SCTT in a park bench position, a lumbar drain is absolutely indicated. This will allow you to drain CSF during the craniotomy and open up the supracerebellar space. Patient positioning is always important in neurosurgery, and patient positioning during an SCT approach is absolutely critical. The position of park bench is standard. for this approach with the patient in the lateral recumbent position with the pathology side facing the sky. You want to elevate the torso at least 15 degrees to favor venous drainage and reduce blood contamination of the field. And the position of the head is absolutely critical in order to firstly optimize the positioning in and around the shoulder. You're going to want to retract the shoulder down gently in order to give yourself a working area, and you're going to want to rotate the head with the face towards the floor, towards the contralateral side, and flex the vertex towards the floor. These maneuvers will bring the lateral portion of the cerebellum, or the paramedian region, to the epicenter of your working corridor, and will optimize your approach to the supracerebellar space. If you don't rotate the head sufficiently, you're going to come in too lateral, and it'll make your approach much more difficult. Now, I work mostly with children, and rotating the head is very rarely an issue. But of course, if your patient has a short neck, if they're obese, if they're bulky, this could potentially be a limiting factor that would render the surgery more technically challenging. Neuronavigation is a very useful adjunct for the SCTT approach. Here we're using it for planning the incision and really localizing the transverse sinus precisely. But as you'll see, it's used throughout the procedure, and it's very, very useful. So the incision is essentially a paramedian. I do an S-shaped incision, mid-distance between the occipital protuberance and the mastoid process. Once the exposure is done, you want to do a craniotomy that is both spanning the transverse sinus, 1/3 above and 2/3 below. You do not need to expose the foramen magnum in this approach. Very important to expose the complete exposure of the transverse sinus, as I'll show in the following slides. It's also very important to perform a craniotomy that extends from the midline, so exposing up to the occipital sinus to the sigmoid sinus. This medial lateral exposure is very important. Why? You'll need this working corridor in order to be able to manipulate the tissue farther down. It's a procedure in which the length of your working corridor is quite long, and having this medial lateral coverage really becomes important. The second reason why this medial lateral exposure is important is during the supracerebellar dissection. Once the dura is open and you're dissecting above the cerebellum to reach the quadrigeminal cistern, you're going to encounter bridging veins. If your medial lateral exposure is too limited, you're going to either be forced to sacrifice one or two of these bridging veins that you encounter over the hemisphere, or you'll be very limited if you're in working around them. This illustration is an excellent demonstration of why, in addition to having a wide medial lateral craniotomy, you want to make sure you expose the transverse sinus. In this example, the transverse sinus was not exposed, the dura was open and reflected superiorly, but as you can see, the working corridor of the supracerebellar space, which is already a narrow corridor to be working through, stays quite narrow. However, once you extend the craniotomy above the transverse sinus, and you'll do tack-up sutures on the posterior fossa dura, in addition to on the tentorial dura, you're able to open up that space, and you'll get precious millimeters of exposure in the supracerebellar space that will be absolutely critical to improving your exposure. So once the craniotomy is performed, you'll want to open the dura. Again, generous medial lateral coverage from just lateral to the occipital sinus, extending laterally to just medial to the sigmoid sinus. And this again will give you a good medial lateral working corridor and maneuverability. The next step is to dissect the supracerebellar space. The goal primarily is to have a generous exposure of the tentorium for your eventual transtentorial approach, for your tentorial opening. But the secondary objective is to reach the quadrigeminal and ambient cisterns. Now, there's two things to really look out for when you're performing your supracerebellar dissection. Firstly, you want to start out really at the epicenter of your craniotomy, at the middle of your cerebellum. Why? As you all know, the cerebellum has a supermedial to inferolateral slope. So if you go too medial, you'll be working in a more restrained space. Whereas if you go at a more lateral mid-cerebellar portion to start your dissection, you're working in a space where there's a more rostrocaudal exposure. The second important consideration in the supracerebellar dissection is the bridging veins. So, of course, the cerebellum has many bridging veins, paramedian, lateral, but also hemispheric. You won't really be exposing significantly the median or the lateral, but you will encounter likely at least one, if not two, hemispheric bridging veins. You can sacrifice them without complication, without cerebellar edema or venous infarction. In general, that tends to occur when hemispheric and midline, or just midline or lateral, are sacrificed. That being said, as a general rule of thumb, I always try and preserve these bridging veins, and in most cases, you're able to work around them. So once you perform your supracerebellar dissection and extend towards the quadrigeminal ambient cistern, you're going to want to expose these spaces. The goal of this step in exposing the perimesencephalic cistern is to obtain your neurovascular control. Prior to opening the tentorium, you're going to want to identify the midbrain, the PCA, the SCA, the tributaries to the vena gallon, and most importantly, the trochlear nerve. The trochlear nerve will be essential in prior to opening the tentorium to ensure to not damage it upon the medial opening the tentorium. And you're going to want this neurovascular control so that when you're resecting the medial basal temporal structures, you're cognizant and you have visual spatial awareness of where these structures are, so to be sure to protect them. So how do you open the tentorium? There's several ways: T-shaped incision or resection of the tentorium. I've been using just a linear opening of the tentorium. Neuronavigation is extremely useful at this step. You want to open the tentorium from a lateral to a medial direction, extending from about the mid portion of the tentorium, extending medially to the free edge. And your goal is to really extend medially as far posteriorly as you can towards the confluence of the sinus, the vena gallon, but of course without at least a couple millimeters, without risking those structures. Why? You want to absolutely be free of the trochlear nerve as it enters the leaflets of the tentorium. A general rule of thumb is that if your tentorial opening at the free edge of the tentorium is behind the tectum of the midbrain, you're free of the trochlear nerve. And neuronavigation is very useful for this stage to ensure good positioning of your tentorial opening. So a couple other pearls to consider. I haven't run into this finding, but it's been reported a trigeminal vagal reflex when opening the tentorium. So you always want to notify the anesthetist that you'll be manipulating and opening the tentorium, as there could be a risk of cardiac changes. And of course, as I mentioned, you're going to want to be cognizant of bridging veins, adapt your incision to preserve bridging veins or venous sinuses within the tentorium whenever possible. So once you've opened and retracted the tentorium, you'll visualize the medial basal temporal lobe. In general, if you've opened it just anterior to the falcotentorial junction, you'll visualize the most posterior extent of the medial basal temporal region, the posterior parahippocampal gyrus, the collateral sulcus and the fusiform gyrus, and potentially the anterior portion of the lingular gyrus. And of course, you'll visualize the neurovascular structures that you've exposed in the quadrigeminal and ambient cistern. It's important to note that in tumor pathology will, of course, obscure this normal anatomy. Now, I'm not going to go into detail over the steps of performing a selective amygdalohippocapectomy, through this approach. Other than showing this sort of demonstration and sort of illustrating that the anatomy is anatomy that anyone that's habituated with performing selective amygdalohippocapectomies, it's the similar anatomy and the similar steps, but you're seeing these steps and you're seeing the anatomy from a posterior standpoint, and so usually when you're removing the hippocampus, the parahippocampal structures and the hippocampus from this point, you'll start at just posterior to the inferior colliculus, and that will be the posterior portion of the parahippocampal gyrus, and you'll extend anteriorly towards the subiculum, resect the subiculum, extend towards the uncus, and as you go, you'll be carrying out the same steps you usually carry out, whether it be from a transsylvian or a transtemporal, but rather from a posterior standpoint. And so, for the sake of time, I won't go through the details of these steps, but of course, it would be important to review the anatomy that you usually see from an anterior lateral or a lateral standpoint, but from an inferior posterior lateral point of view. And this is an example of a resection of the amygdala and hippocampus from a SCTAT approach. I'm going to go into a illustrative surgical video of a young 9-year-old boy with refractory MTLE, with whom we found a neoplastic lesion in the posterior portion of the medial-basal temporal lobe. Because this lesion was calcified, laser ablation was not considered an option, and I thought that the SCTAT approach was an ideal surgical approach for this patient. So here he is positioned in a park bench with the right side facing up. Lumbar drain is placed in order to get an egress to CSF and open up the supracerebellar space. Exposure of the suboccipital bone, transverse sinus, sigmoid sinus, and midline all need to be exposed. And again, very important, generous medial-lateral exposure from midline to sigmoid sinus, and craniotomy that extends about 6 centimeters, 1/3 above, 2/3 below the transverse sinus. No need to open the foramen magnum. Once your craniotomy is performed, you open the dura, of course, in a C-shaped fashion, and you'll reflect the dura superiorly towards the transverse sinus. So here we are opening up the cisterna magna. Without opening the foramen magnum, you can still gently retract the cerebellum, and here I am opening the cisterna magna, obtaining further egress to CSF. I can't stress enough how critical it is to get maximal CSF egress through lumbar drain or cisterna magna. Next step, of course, is supracerebellar dissection, starting at the optimal position of the cerebellum at the mid-distance and extending towards the quadrigeminal cistern. In this case, there was a bridging vein which we preserved. Here I am extending to the quadrigeminal cistern, and you're going to want to open up and expose the inferior colliculi. Immediately, you'll encounter some thick arachnoid. That's generally quite the standard for the pineal region, and you'll want to expose the tributaries to the vein of Galen. Next, you'll want to expose the midbrain, more specifically the inferior colliculus, the superior cerebellar artery, which you see here. And then once you've exposed the inferior colliculus and the superior cerebellar artery, you can extend laterally along the quadrigeminal cistern. And here I am retracting gently the cerebellum. You see the midbrain, both the rostral and the caudal trunk of the superior cerebellar artery, and the fourth cranial nerve. This is a critical step of this step of the procedure, and you'll want to follow the fourth cranial nerve all the way from its cisternal segment to its tentorial segment, where it enters the tentorium, so that you can later safely open the tent and preserve. Oops, it seems like my video kind of cut out. So I'll go back. So neuronavigation is extremely important at this step of opening the tentorium. You'll want to open from a lateral to a medial direction, from the mid portion to the free edge close to vein of Galen. And in this case, I encountered a hemispheric bridging vein, and so I modified my exposure to just medial of that vein, medial to this tentorial sinus, down towards the tentorial free edge. Now, it's important to have hemoclips on standby in case you do encounter or open the sinus within the tentorium. You'll coagulate the tentorium, incise it with a beaver, and then open it with micro scissors. You can place a small cottonoid patty above the tentorium to protect the basal surface of the temporal occipital lobe. Once you've opened it all the way to the free edge, then you want to place Neurolon foro sutures. You can, in general, place 1 or 2 on either side of the leaflet. In this case, I only put 1 on the anterior lateral leaflet, and I retracted it down. Important, of course, to protect the cerebellum with telfa patties while retracting it with the foro-neurolon stitch. So once you've opened the tentorium and retracted it, both leaflets, you'll expose the inferior surface of the temporal occipital lobe. And in general, reliable landmark will be the collateral sulcus and the parahippocampal or fusiform gyrus. Of course, in cases of neoplasms like this one, that anatomy can be obscured. Neuronavigation is, of course, very useful. And you'll want to, in cases of neoplasms, open the cortex just posterior and inferior. It's very important to note that intraoperative electrocorticography can be used. In general, a 4-contact strip can be slid under the inferior surface of the parahippocampal gyrus. So at this stage, you want to perform the corticectomy at the portion where the cortex is thinnest, and at the posterior portion of where the tumor is. I generally start medial, close to the pial surface where the posterior cerebral arteries are. And this is the most important part of this step, is to expose these posterior cerebral arteries, both the inferior temporal arteries, but also the parietal, occipital, and calcarine branches, because inadvertent injury to these would obviously cause damage to visual pathways. Once you've exposed the posterior cerebral arteries, then standard microsurgical technique for resection of the tumor. So internal debulking with suction if it's a malleable or friable tumor. If not, the CUSA can be utilized. And with internal debulking, extracapsular dissection whenever possible. You can, in a piecemeal fashion, remove the tumor that in general occupies the posterior parahippocampal and sometimes fusiform gyrus. In general, I don't use fixed retractors. As you can see in this case, dynamic retraction was used throughout. And here's the immediate postoperative scan. This patient is 2 years post-op and is seizure-free with no tumor recurrence. So I hope I've shown through this brief talk that the SCTT approach is an excellent option to reach the medial basal temporal lobe. It can certainly reduce approach-related injury to eloquent temporal or occipital structures, whether visual field or language or memory pathways. Of course, there are important pearls and pitfalls at each step of the way. Imperative to have excellent working knowledge of the surgical anatomy, to assess each patient's intrinsic anatomy, in particularly their tentorial angle and venous drainage. Of course, every step of the surgery, there are important pearls to note, any from positioning to utilization of the lumbar drain to having a generous craniotomy to improve your window, your supracerebellar window, which will improve the opening of this already quite narrow corridor. As much as possible, preserve the bridging veins during your supracerebellar approach. absolutely critical before opening the tentorium to identify the perimesencephalic structures. And then during MTR resection, there are some landmarks at the base of the cortical surface of the basal occipital-temporal lobe, in particular the collateral sulcus. And in general, I start my resection as much as possible subpially, if possible, and I try and expose, usually starting with a suction to be as safe as possible, but I try and expose the passing through branches of the PCA. One final thing is when you're working deep, you have to be very cognizant of the bridging veins extending above the cerebellum to the tentorium. There's of course risk of avulsion and also risk of microscope-induced heating of the bridging vein. So important to keep it hydrated to avoid inadvertent sacrifice of the vein. Of course, familiarity, pardon me, with the mesial structures and being able to identify them from behind and from below is absolutely critical in order to safely carry out this procedure. Thank you.
Thank you so much, Alex. I think this was a very detailed and very comprehensive review. I appreciate very, very much. It was wonderful. I think we have perhaps 5 minutes for discussions, and I will probably address, I don't think we're going to be able to answer all the questions, but we will send the questions to the speakers and they will reply to you. So all your questions will be answered. I am just going through some of those questions, and I would like, I think I see here Dr. Byron Bonilla. He has a question for Dr. Smith. I will read it. Thanks for such outstanding lecture. How do you deal with venous system variability, considerable size and anterior located lobe, blocking the subtemporal approach? I think this is a question for Dr. Smith.
Yes, well, that's a great question. I think that initially I had more fear of it than I do now after having a lot of more experience. And as I said, instead of lifting the veins upward, I simply go over the vein and leave the vein down. So the vein is not retracted up to avoid avulsion. So I alter my entry point into the collateral sulcus or into, sometimes admittedly cheat into the fusiform gyrus if the vein is going to be at risk by pulling it up. I've never had to sacrifice a vein or had a venous avulsion problem. A couple times there was some mild oozing and just simply stopped retracting, place some, and I'm a believer in dynamic retraction. I haven't used a Greenberg retractor for several years on one of these, but it's again becomes a comfort level thing with a dynamic retraction. I certainly did it a lot. And initially I didn't think this operation was possible without a Greenberg at first until Dr. Spetzler challenged me on it. And then I do it that way all the time now. So it's something about retraction, but by not having a fixed retractor, I'm not pulling up severely on the vein of Lobe structures, and by going up and over the vein instead of pulling the vein up with you has been my mechanism of avoiding injury.
Wonderful. I have now a question for Dr. Weil from Enrico Ghizzoni. I'll read it. Dear Dr. Weil, thank you for your excellent presentation. Which are the main advantages of the supracerebellar transtentorial approach over the occipital interhemispheric approach to posterior mesotemporal lobe pathology? I think this is an interesting question.
Yeah, very good question. Thank you. So when addressing a lesion of the posterior mediobasal temporal region, the goal is to preserve vision. And the disadvantage of the occipital interhemispheric is you're going to be retracting the primary visual pathways. So there's inherently risk of retraction-induced injury to the primary visual pathways, and whether it be homonymous hemianopsia or quadranopsia. And so the SCTT approach really, by passing underneath and anterior to the primary occipital cortex, you bypass the visual pathways.
Okay, very good.
I'd say that's the main advantage.
Sounds good. I'd like to open the questions for our panelists here. Guy, Artur, Bertel, Chris, any questions for our speakers?
Yeah, Jorge, hi, it's Guy. I have a question for both speakers, but I know that particularly for Chris, that Chris and Dr. Spetzler have a lot of experience with the occipital interhemispheric approach. And in your hands, how do you decide that same last question, when to go supracerebellar versus occipital interhemispheric to the posterior medial basal region?
Yeah, for me, we did publish that together. It's a larger, expose the entire tentorium and go torcula and all the veins and go in medial or under the occipital lobe. And I honestly haven't done that for a long time since we've done the supracerebellar and for tentorial. I certainly favor that. I think Alex Wiles' presentation of that showed that beautifully. Being a minimalist, I do it a little bit smaller, and I don't want to counter, his points, but I also, it's kind of sacrilege, but I don't use a lumbar drain. I don't, because I've become comfortable in changing the position of the patient with the reverse Trendelenburg at the beginning, the same tricks that I do with the subtemporal. I've found that I think the positioning is absolutely critical. A park bench, I love it. Because I can do reverse Trendelenburg at the beginning and get everything relaxed, similar to a sitting. And then as the operation proceeds, I bring them back down to do the operation. So the dynamic table positioning allows that. And I think that by doing that and avoiding exposure of as many veins and avoiding that retraction, we found in the occipital interhemispheric or suboccipital, that occipital lobe wants to come out at you, whereas going underneath and over the cerebellum, it's and through the tentorium, you don't have any of that occipital lobe retraction. You get directly to that medial posterior occipital lesion, just like he showed, and I definitely favor that.
Thank you, Chris. Perhaps we have a time for one more questions. Any, perhaps Artur or
Yeah, Jorge, I just noticed that Carl Horsel has a couple of questions and I brought him to the panel. So Carl, are you there? If you are there, you have to unmute and ask your questions.
Yeah, I have unmuted.
And show yourself. Oh, that's good.
Okay, I've started the video now. Okay, thank you.
So go ahead with your questions.
Yes, so one of my questions was that the subtemporal approach, the start, it looked like as if you are going transtemporal, not subtemporal, but transtemporal. Am I right, or did it only look at the video like this?
No, there's no tentorial, no transtemporal.
No.
It's all underneath.
Okay. Yeah. And the question to the supracerebellar approach was if it is also good for a standard amygdalohippocampectomy, not only in lesional cases, but also in hippocampal sclerosis. And the second one is if it is possible to do a block resection to get a good histology from your specimen.
That's an excellent question. So you can absolutely do a selective amygdalohypocampectomy through the SCTT approach. So essentially resecting the anterior and middle portions of the medial basal temporal lobe. So it is feasible. There's not many groups that do it. And the groups that do it have a lot of experience. So it's reaching the most anterior portion is a far reach from the cerebellum to the uncus is a long reach. It's doable, it's feasible, it's been shown safe and effective in the centers that have done it with good seizure outcome, low morbidity, low 0 to 9% visual field dysfunction, and almost no neurological morbidity. There's one series with a very low rate of transient trochlear nerve injury. So it's very feasible, but it's difficult. Reaching the hippocampus, as we all know, it wraps around the midbrain. And when you're coming from that approach, you have to deal with laterally, there's the petrous ridge, and medially it wraps around the midbrain. So reaching the anterior structures is challenging. And some authors have placed like cottonoids underneath the parahippocampal gyrus to lift it up and bring it into your field of view, but it's challenging. Other authors have used an endoscope as an adjunct to improve visualization as they extend anteriorly. So yes, it is feasible. To answer the first part of your question, remind me the second part.
If it is possible to do a en bloc resection, if you want to have a good specimen for histological preparation.
Yeah. Great question. So obviously neoplastic, which is the majority of my experience, it's piecemeal as I showed, but actually the selective amygdalohippocapectomy through the SCT approach it's en bloc, and oftentimes you can even get a better specimen than when you go transtemporal or after a standard temporal lobectomy. Essentially, you're coming at the medial basal temporal lobe posteriorly and inferiorly, and you have visualization of the tectum of the midbrain and visualization from underneath of the parahippocampal gyrus, and lateral to that the collateral sulcus. So you actually have, at the start of your hippocampectomy or medial structure resection, you already have your posterior limit. You start from the posterior limit, so you have a good estimation. You're able to get a complete resection from the get-go. And once you open the parahippocampal gyrus from inferiorly, you can actually remove, as you extend, in general, you resect the parahippocampal gyrus through resection technique, but the hippocampus can be elevated from the body and the head en bloc. And that's actually easier than through a lateral transtemporal approach, as you lift it off with the fimbriae off the choroidal fissure. So
yeah.
So long-winded answer to say yes, you can do selective SAH, and yes, you can resect it en bloc for good pathology and research.
Okay, thank you very much for your excellent explanations.
Yeah, if I could chime in on that, I think it's having done both approaches, and again, I think Alex Wild's presentation and the possibility of doing it through a supercerebellar transtentorial approach is feasible. I've been there. I just think that the risk of complication of a posterior fossa approach is inherently higher than a supratentorial approach. Not that it can't be done and groups do it safely. I get more anxiety over the postoperative course of any posterior fossa operation as opposed to a supratentorial one, and maybe that's justified or not, but admittedly that is a long reach from behind to get to the amygdala, and one of our residents is preparing a series of what I call hippocampal gliomas that kind of span this, and it depends on back. I use the exact same principles of the subtemporal amygdala hippocampectomy to do those hippocampal gliomas as I do doing the procedure. But I think that if it's a primarily posterior lesion like the one you showed, I would favor the supercerebellar transtentorial now rather than lifting up and back to get there. But if it's a more anterior pathology, I would clearly favor the subtemporal. But that's just my opinion.
Thank you very much.
Very good. So I think it's past the time. I'd like to conclude this session. I would, first of all, I'd like to thank you, our outstanding speakers, for wonderful presentation. Chris and Alex, thank you so much. Please stay tuned for the next webinar. It's going to be September 20th. We are going to talk about surgical approaches for hemispheric epilepsy. So there are a lot of questions that were not answered because of time limitations, but we will send those questions to the speakers and they will reply to your questions. So stay tuned for that as well. Without any more delays, I'd like to thank you all, the speakers, participants, panelists for this wonderful seminar, and stay tuned for the next time. Thank you.